Good morning, everybody. Welcome to the MND Association webinar on the introduction on the new wheelchair pathway. My name's Pauline and I'm the Head of National Care at the MND Association. And MND webinars have been designed to fit within your working day. You have the chance to ask questions and discuss what you've heard today. So the aim of the webinar is to support professionals such as yourselves to review and evaluate wheelchair provision for those living with MND. Before I hand over to our speakers, can I ask that everyone keeps their cells on mute and video turned off unless asked otherwise. If you've got any questions, please use the chat function. So we'll be monitoring that throughout the session, or use your thumbs up or the little emoji, and then we'll invite you to unmute your microphone and ask a question when appropriate. So the webinar will be recorded and available to watch after the event. We'll also share a link to our evaluation at the end of the presentation, as well as links to additional resources. We're also going to be sending out some feedback, so please let us know how you felt today went and how we might be able to improve it for next time. So without further ado, I'd like to introduce you to our speakers. So we have Jenny Rolfe, Senior Occupational Therapist from the MND Oxford Care Centre, Lynn Hills, Occupational Therapist, who's based at the MND Care Centre at the National Hospital and the Queen Elizabeth Foundation for Mobility, and Alison Johnson, Wheelchair Therapist based at King's College Hospital in London. So without further ado, I'll hand you over to Jenny Rolfe.
Thanks, Pauline. Good morning, everybody. I know Alison will be jumping, so I'm going to say Alison's a physio. So she's a wheelchair therapist, but a physiotherapist. So thank you very much for joining us today. Hopefully you'll find it helpful. I can't see the chat whilst I'm presenting, so somebody will keep an eye on that. So any questions for me as I'm going through, I'll come to towards the end. So my part in this session is to just give you a bit of background, really. Some of you may be aware that we in the association have been working with wheelchair services for a number of years now. So going way back to 2007 is when I started with the association and the project to help improve service provision for people with MND. And mainly that was being driven by wheelchair services themselves, but also people living with MND, and many people were actually dying before they got their chairs. And one of the main problems wheelchair services were having was that they were forever playing catch up and never being able to get somebody a product that they could use. So in 2009, the Department of Health approached the association to map out what we thought would be the ideal for our patient group, which we did, and that gave birth to the first pathway. And we had a number of consultation processes where we consulted wheelchair services themselves, managers, clinicians, obviously users, manufacturers, and we came up with a pathway which is the one that we've reviewed and we'll be concentrating on for the rest of the presentation today. But just to give you a background to that, at that time, the Department of Health was looking at a method of service delivery called any qualified provider, which I'm not going to go into any details of, but because it's no longer there. But it enabled us as the association to apply for a grant for some money, and that funded a project which was the powered neuro wheelchair. And this was really aimed to support wheelchair prescribers in prescribing something that would last somebody with MND throughout the course of their disease, so that we weren't playing catch up all the time. And again, that process of development of the chair involved wheelchair manufacturers, users, wheelchair service providers, commissioners, clinicians, engineers, and the aim of it was really to speed up provision and use anticipatory prescribing, so we weren't playing catch up. So where we are now is obviously that's quite a long time ago, 2009. Here we are, 2021, and we where I apologise, I'm having building work done and somebody is demolishing part of my house around me. So if you hear banging and crashing, I do apologise for that. So we decided that we really did need to review this pathway. There was lots of references to the things that were around at the time when it was written, such as any qualified provider. There's been a constant discussion amongst clinicians and ourselves as to things like, should we have timescales on different parts of the pathway or not? And so we thought what we needed to do now was to review what we were sharing with yourselves. There was, since we written the pathway, the NICE had written guidelines with regards to the management of MND in all areas of their care, but there is specific mentions of wheelchair provision in the NICE guidelines. And so we really wanted to encompass how things had changed. Thankfully, people were no longer waiting over a year for a power chair. Things have moved on. There's lots of different providers out there now. So the likes of NRS, Millbrook, AJ, you know, a number of private companies are now providers of statutory services. So we needed our pathway to represent a different time, really. So the aim of this session is to go through the pathway with you and hopefully show you where that might fit into your practice. So the aims of the pathway, so to help you work out how you can best deliver. Now, there's been a massive improvement since 2007, 2009, thankfully, but there are still lots of challenges, and obviously COVID is the next biggest challenge that we all are facing. So it's looking at how you within your services can maybe look at your practice and improve things slightly. And although this is based for MND patients, I have to say it's applicable across the board to anybody with perhaps a rapid change, a period of change in their condition, or who is in acute phase, or is in a rapidly progressive condition. So the aim of the pathway, although it's written for MND and hopefully you can apply it for MND, you might find it useful to apply across the board. The aim is really to help you make things more timely and get the right kit out at the right time. We hopefully will help reduce the amount of multiple provision of chairs, and although that is reduced a lot since the launch of the neuro chair and the development of people's skills and understanding about what people with MND need, there is still sometimes a number of chairs that are provided, especially where stock isn't available. So somebody might have a chair as a stopgap and things like that. So the pathway might help try and enable you to plan having more stock available at the right time, and hopefully learn from the experiences that we've all had to learn recently with the COVID time, and how we've all had to change our practice and in incorporating new ways of practice that we've all had to embrace, such as the virtual assessments. And actually it's opened the door, and I'm not going to steal the thunder from Alison and Lynn that will go through things, but you know, now we are now on Zoom, we're able to embrace this technology, whereas before we were kind of like, I can't virtually have another therapist on an assessment with me, but maybe now we can. So to back up what we needed to change, there was a survey that we sent out from the MND Association, and it was actually sent more to multidisciplinary teams and some wheelchair services. So you may have been involved with that, but the results were really interesting, and it brought up quite a lot of interesting facts for us. And there is a bit of work we want to go forward with to try and help. And one of the things was that sometimes the referral process and who refers for what was very, nobody seemed to know, nobody took ownership of who referred where, very different in different areas. I'm just going to move my thumbnails because I can't see my slide. There we go. when people received referrals, so at what point in the disease process are wheelchair services receiving referrals? Is it early? Is it too late? How those referrals are triaged, and what information is gathered at that point, and the general knowledge about personal wheelchair budgets, and looking holistically were the biggies that were kind of, for us, things that came out that showed us that we needed to help improve people's knowledge and understanding, and assist in how we can improve ways of working. So for some reason my computer's not, there we go. So this was just to give you a visual picture of, do you refer to social services at the same time as you refer to wheelchair services? So we asked people who are referring whether they referred to the community OTs at the point in time where they're referring to the wheelchair therapists to look at access, and you can see there that the large majority don't. So there's a, you know, that's a big hiccup, we know from wheelchair services, that and our experience, that you can't put a chair in somebody's house if it's not accessible. So there's an issue. And then the personal wheelchair budget thing, so it's about half and half, and this was a mixture of people that answered that question. Now, Lynn and Alison are going to go on and explain a little bit more about these, but I just wanted to demonstrate the rationale behind why we needed to change our pathway. So I'm going to hand over to Lynn. So I'm going to stop sharing my screen. Please do write any questions in the message if you've got any for me specifically, and I can answer them as we're going along, but otherwise I will hand over to Lynn. Thank you. Lynn, you need to unmute.
Sorry. Has my screen come up? Okay. Hi everyone, I'm Lynn, and thanks Jenny for that. It's really lovely to join you today and share some of the work that's been keeping us occupied really over the past few months. I've got the pleasure of introducing the new pathway which we're launching today, so you're the first people to see it. As Jenny said, this is a new 2021 pathway that we've been working on following the results of the survey, and it's hopefully a resource that will assist those working with this client group in promoting the optimal wheelchair provision for those living with MND. It's known that around 80% of those people diagnosed with MND will require a wheelchair at some point of their disease progression. And with all of our experience in working with this condition, we know it's important to provide appropriate assistive equipment that can return or prolong function as much as possible. As Jenny's already highlighted, much of the work that's been done over the past few years to look at this client group and work towards the identification of a wheelchair that would meet both an individual's intermediate as well as longer term needs, whilst addressing their changing needs as their condition progresses, which for most of us know this can be a real challenge. We've learned through our own work and working with many of you that there are key things that can be done throughout this process and help us with timely and effective provision, and we hope we've translated this knowledge and experience into the pathway to aid this process. So today we'll look at the whole process, from the identification that there's been a change in someone's function of someone living with MND, about making that referral and how this referral is triaged. We'll touch on the assessment of this client group and identify some of their key presentations and how this can impact on the assessment process. And then we'll move on to ordering the equipment, issue, handover of the provision, and then move on to review. So if we look at the first part of the pathway about introducing a wheelchair to somebody, hopefully my slides move. Okay. So discussion around wheelchairs is never an easy topic to introduce. So quite a few individuals will think that getting a wheelchair is a sign that things are getting worse. And often when someone presents with some level of mobility, they don't want a chair to replace this, often stating if they don't use it, they will lose it. However, we know wheelchairs can optimise independence, and this can often complement any existing function that an individual has. So acceptances are often our biggest barrier in introducing wheelchairs and making that initial referral. Early discussions around wheelchair provision are really important to plant a seed, and acceptance of these discussions can be really varied. Whilst attending the clinic up at Queen Square, I'm often the first person to have a discussion around wheelchairs and what these actually are and how they can support you. And for me, I think it's a really wonderful position to be in, and I see it as a privilege that I'm often the first person to provide them with the right information at what I think is the right time. And when you ask what is the right time, I really believe that this has to be before it is necessary. So if we look and move on to referral and triage, we know from our work and experience that early referral is key, and this is underpinned through the NICE guidelines that Alison will go through shortly, which identify that referral to wheelchair services should be made without delay. If you're the person making the referral or screening it, it's important to consider any onward referrals that need to be made. We know from discussions with individuals where there are going to be issues with the environment, and it's important at this early stage to make the referral through to the right service to assess them for the potential for home adaptations. And ideally, these referrals should be made simultaneously. The use of video calls has really assisted this process over the past few months and often identified whether there's going to be potential issues and the need for onward referral. Therefore, So you may through this screening process make a decision that the client is now, it's not the right time for them to pursue power provision, and they may just require a manual wheelchair. But onward referral to assess the environment will still support future intervention and should be considered. So at the moment, I'm working with a wheelchair service where the client didn't wish to pursue a powered wheelchair quite yet, but an environmental assessment has been completed to prepare for when this is needed. And this will obviously ease the process when the time is ready to prescribe. So the information gathered at this point will really allow you on how best to proceed. It will identify the type of intervention that an individual is likely to need, what type of clinical input will be required, and it can help with caseload planning and skill mix. We know from the previous champions training that was carried out through the MND Association that having a named personal champion allocated can be key in managing these individuals with MND. They can provide the knowledge on the disease process and act as a link in coordinating with the wider MDT, and we're often a resource as well if people need us. So absolutely, it really helps to understand the disease progression in order to identify the most effective and anticipatory intervention. So for example, there'll be a different approach for individuals presenting with ALS in comparison to PLS or Kennedy's disease. So understanding their presentations and how they impact on their posture and seating needs is really key to service delivery. Now, I'm not going to touch on all the different presentations today, but I thought it might be helpful for those not too familiar with the disease progression, just to give a really brief overview of the general picture seen. Obviously, everybody's very different in their presentations. So this slide looks at the general changes seen and can help us predict with future changes in mobility. So initially, you will see a reduction in someone's general mobility and function, and this is usually they're referred to us in the first place. They may present with lower limb weakness, possible foot drop, occasional falls, and the inability to walk longer distances. And they may have already some community teams involved, but you may also be the first person. And then you're likely to see a reduction in their outdoor mobility, where the individual will present with increased weakness, and they're only walking short distances, falls are perhaps increasing in frequency, and they may be furniture walking, and they may need help with some of their functional transfers, for example, getting in and out of a car, on and off bed, etc. Where weight bearing is limited and the individual may only be walking very, very slightly, and there's an increase in falls, they're more likely to be a daily wheelchair user, and they may start to present with trunk, upper limb and neck weakness, and also experience difficulty with transfers and be using some equipment. And then moving on to where somebody is a full-time wheelchair user and possibly likely to require a hoist for transfers. The key to this group of patients is that things are progressive, so get worse over time, and this can be rapid or slowly. This is something that's always discussed in clinic, that everyone's presentation is different, and although there are some common presentations, it really does vary with individuals. However, ultimately they all result in a loss of movement and function, and by having an understanding of the disease progress and its presentation, we can understand some of the key presentations that we see in relation to posture and functions, such as their body position of their pelvis, trunk and head. And this knowledge can really help inform our practice and influence our assessment and prescription process. So if we look at some of these briefly, very simply, there's a loss of altered motor function which impacts on an individual's ability to balance and maintain their posture against gravity, and this leads to a deterioration in their seated posture and function. Through our understanding of the typical postures seen, it can help us to ensure what we are going to prescribe now will meet their longer term needs, even if it's not required now. So this is probably a whole presentation in itself, but just to touch on some of the typical postures that we see. Posterior pelvic tilt, which is often adopted due to the lack of postural control and the need to create some stability in the trunk and provide a stable base for upper limb function. It's commonly seen and often seen very early on. Along with this, you'll see a flexed upper kyphosis and a flexed neck posture, which can be one of the most trickiest things to manage when looking at seating. And I thought it might be quite good to add at this point, because I didn't really know where else to add it, is to consider early referral for collar provision when you start to see changes for their neck posture. In my experience, early collar provision, even if it's just worn for short periods, leads to increase in acceptance and the usage of the collar, and it can really assist in optimising the seating of individuals when they experience this problem. Another method for predicting some of the changes seen is the use of an outcome measure, the ALS-FRS. This is a functional ratings tool that is used often in clinic to help inform our practice. The type of MND onset can give an indication as to how fast a disease progresses. For example, bulbar onset sees a faster progression than spinal and limb. And with the ALS-FRS, when someone has a score of 25 or higher, you'll see a presentation of reduced general mobility, and this will identify the need of somebody perhaps needing something like a lightweight manual chair. When someone scores 25 or over, they're likely to need a powered wheelchair provision or provision of a tilting space chair. However, what the tool doesn't offer you are the details on upper limb, hand or head function when considering things like alternative controls, so we just need to consider this as part of our prescription. So if we move on to the assessment process, from our understanding of the disease, and from the information we've gathered at referral and triage, it will help inform us how we can progress at the assessment and how we can make the process as efficient as possible. We know that for anyone going through the process of receiving a power chair, it can be a challenge to ensure that they meet all the needs of the user, and we know that these needs can be plentiful. So during the prescription of a chair, we're looking at safe and comfortable support to address progressive weakness and the physical changes, the ability to manoeuvre in environments with limited space, as well as handle a broad range of surfaces both in and outdoors, the flexibility to adjust the wheelchair as the needs change and have the technology to cope with its potential for specialist controls, and the ability to meet the needs of the lifestyle and vehicle needs of the user, which are quite a lot to consider. This can be a challenge for anyone going through the process of powered wheelchair prescription, but the challenge with MND is the timing of this and to ensure that provision has optimal longevity. So we know from the research previously carried out that users place high demands on the wheelchair services and therapists' time due to their continually changing needs, often resulting in frequent changes of equipment and delays in getting the equipment in place at the right time. Over the years, and with the promotion of the NeuroChair concept, there have been improvements where we can identify a chair that can be adjusted and modified easily as the individual's presentation changes. This will save time in terms of future adjustments to be made or potentially added to the chair. We want to prevent wastage and also promote potential reuse of the equipment. Supporting of all this process is the role of education and pointing those living with MND to invaluable resources that will support any decision making. For example, understanding how wheelchairs are transported, what is a power chair, what does it look like, how does it function, and what are my options. There are lots of research resources out there to support this part of the assessment, and the MND Association has some really helpful and easy to read fact sheets and videos that often I send out following my initial screening call, and I think they can be added to the chat if people are keen to see what they are. So when completing a specialist wheelchair assessment, consider where will this be completed? Can it be completed at home? And if a chair can the chair be issued if it's successful? Early environmental assessments will really support this process and reduce some of the visits that are needed. Another consideration during this process is whether the individual is working or in education, albeit that that's rare, and how will this wheelchair be used as part of this process? And can we work with employers or other establishments to help with sources of funding? So working with the community team is both essential and complementary during the process of prescription, and it can enable some additional features to be identified. So for example, if someone's experiencing difficulty with functional transfers in their therapy sessions, possibly a riser may assist in promoting optimal wheelchair setup for those functional transfers. Joint working can also identify whether any additional equipment needs can be mounted to the chair, and whether any required equipment can be ordered at the same time by the right team member to work towards all the equipment being set up at the same time, for example, eye gaze mounts. So we've just recently completed an assessment for a lady who needed a power chair with a head array, and she was using an eye gaze mount. So at the point of prescription, all the team members were made aware what the final provision was going to be. So all the required paperwork could be completed for the eye gaze mounting bracket and ordered, with the goal of this being fitted at the same time as handover. So if any additional features are identified as part of the assessment process, then a personal wheelchair budget may need to be considered. Such features may be over and above what the wheelchair service can provide, for example, attendant controls, seat risers, powered ELRs, or specialist controls. The MND Association could consider supporting some additional features through their grant process, which I think Pauline's going to touch on at the end of the presentation. So as part of this process, it's important to be clear where the responsibility lies for maintenance, and this should be clear at the point of prescription so that the client with MND knows what they're going to be maintaining. So if we move on to the ordering of the chair, following the assessment and when a chair has been identified, we want to look at placing this order. So as Jenny mentioned, we've worked with many of the manufacturers to identify that equipment ordered is marked as a priority for the MND client. And it's key to look at how this is identified as part of your service to ensure that any orders placed are marked with urgency so that the order is processed and the manufacturers clearly know it's for an MND client. When an order is made, it can also be helpful to identify and work towards a handover date and with the right team members so that this optimises timing once the chair has been received. If you're concerned about the wait for whatever reason, it's perhaps worth thinking, could a chair be issued in the interim, or possibly could a chair be hired in this instance? We're often frequently asked to support this process of hiring a chair when there's going to be some delays. And we recently asked to support the hire of a powered wheelchair for a client whilst the wheelchair service made the transition over to another provider. They were concerned about the time it would take for all the new systems to be in place, and the MNDA were able to support this while they waited provision. So if we move on to handover. Ideally, on handover a chair, we want the right people to attend to make this process as efficient as we can. It's likely to depend on what type of controls an individual has been prescribed and how much programme is required for the setup. Different services have different setups and roles and responsibilities to achieve this. It might be that you use external reps to support the process and you've got an identified slot as part of their regular clinic, or perhaps you've got this set up in-house. Handover will also mean having the right family member or carer attending to ensure that they're fully aware of the controls and their function. And this is key to promoting confidence in their handling of the chair and its controls and features. I mentioned education earlier, and this is where it will really support the process with some individuals. Everyone takes to their new provision very differently and may or may not need more support. Obviously, any handover paperwork will be completed at this point, and again, the opportunity to explain the role of the wheelchair services and where responsibilities lie, for example, who will be maintaining what parts of the chair, how to contact the wheelchair service if there are any issues, and also to discuss any insurance that will be required. So moving on to the final slide of review. So falling into the NICE guidelines, all MND care centres nationally set reviews every 3 months to capture the changing progression of the disease. This is seen to be good practice and is perhaps something that could be offered as part of the wheelchair service, whilst recognising at the same time it doesn't always need to be a clinical member of staff who completes the review. Alternatively, you may have an open system for individuals to contact the wheelchair service and to follow up on their mobility if things change. On touching upon re-referral, it's interesting to see how many ways this is completed between services. I know it can be frustrating for the wider MDT if a whole new referral needs to be completed again when the client is already known to the service and their needs change so frequently. It's often asked whether the process could be less paper heavy. Attending the community-based MDT meetings is also another method of review and can update everyone on individual situation. In my experience, I think they're held quite regularly and can be extremely valuable in promoting coordinated care of these really complex clients. Finally, again, my last point is on education, because it's such an important role to play. Through educating others, both staff and also clients with MND, on the likely changes that they may see as part of their functional mobility, this can really help us to be proactive in any adjustments or modifications that might need to be made to keep somebody mobile. So that's the end of my presentation. Thank you for listening. I hope it's highlighted some useful information for you to take away. And I'll hand over to Alison, who's going to discuss the audit aspect of the pathway.
And unmute my microphone as well. Hi, everybody. I'm Alison. Yes, I am a physio, as Jenny mentioned. I'm going to talk through page 2 of the pathway. Basically, we've done it as an audit. This is an audit cycle, which I'm sure you're all very aware of, and you've probably used it many times. Lots of services have to put in audits every year, and hopefully, it's something that you're familiar with as far as your service is concerned. The audit tool also has a cycle on it, and it'll look very familiar because it looks very similar to the first page that Lynn has just talked through. But it's about the audit of referral to provision and review of that. As Jenny said, things have moved on, things have got a lot better, and we're not trying to say that things are still bad. What we'd like to do is to see if we can improve things even further. Okay, so the audit tool, this looks familiar. What I've done is I've split up page 2 into 2 slides so that you're not looking at it like this, because actually it will be in portrait. So what we've done is we've not put any timings in this. Yes, it would be lovely to say this takes 3 days, this takes 2 days, etc. But we know that you are also very subject to manufacturers, suppliers, and things like that. So what we've done is we've left those blank for you to fill in. So you can get yourself a baseline of what's going on at the moment. So this is designed to help you in your provision for people with MND, but as Lynn already, or Jenny already said, that it might actually help in your general provision for everybody. So if I can have the next slide. Page 3. So this is very wordy, but this is the bottom half of that slide, so that sheet of paper. So at the top you'd have that audit cycle with the wheelchair in the middle, familiar picture, and underneath it will have this, which is a lot of the information that Lynn has shared with ideas of how things can be improved, how what things to consider when somebody is making a referral. I'll come back to those in a minute. First, I'd like to just, we've mentioned the NICE guidelines, and here's just a few quotes regarding wheelchairs. So refer people to wheelchair services without delay if needed. Wheelchair needs should be assessed, and a manual and/or powered chair that meets the person's needs should be provided without delay. The reference for these NICE guidelines is at the end, but if you Google NICE guidelines for MND, it will come up anyway. So these are just a few quotes. Ensure that equipment, adaptations, daily living aids, assistive technology and wheelchairs meet the changing needs of the person and their family and/or carers as appropriate to maximise mobility and participation in activities of daily living. Ensure regular ongoing monitoring of the person's mobility and daily life needs and abilities as MND progresses. Regularly review their ability to use equipment and to adapt equipment as necessary. And I think this lovely picture that I found is a young person who decided this is what they wanted their wheelchair to do. And that's what we need to consider. We can't always provide for it, but let's try and consider what they need their wheelchair to do. Healthcare professionals, social care practitioners and other services providing equipment should liaise to ensure that all equipment provided can be integrated. For example, AAC and environmental controls. And you've probably all seen Stephen Hawking's wheelchair, which has a lot of technology fitted to it. So Lynn's given you lots of information, Jenny's given you the background, but what I want to look at is the why and how we can use this audit tool. So why use an audit tool? It can give you a baseline of what's going on currently in your service. This may be different from previously because we're in the middle of a pandemic and staff are being redeployed, and we do appreciate that things are very difficult at the moment. You can compare your current processes with those outlined on the front page 1 of the pathway, as Lynn has talked about. And I'm not saying that this is the best way of doing it, but it's one way of doing it. And it's something that we've used in practice, either in our own wheelchair services that we've worked in, or we've come across as good practice. The other thing is outcome measures. What do you use? Is it too generic? Does it not really specify use of a wheelchair and how people are functioning? And are there better ones? Some of the good ones are FEW, which is functioning every day in a wheelchair. It's very, very wordy, but actually it's quite on point. The other one is TOMS, Therapy Outcome Measures, and that has a section about equipment provision. And there are quite a lot of quality of life audit outcome measures as well, which mean, for our patient group, quality of life is really important. And it's that to remember is an audit is not just about can we do things quicker, but actually can we do things better? Sometimes these things may take a little bit more time, but if we get it right the first time, then that's going to be good for our client group. So how do we use this audit tool? Begin with a process map. I don't know if any of you out there at Wheelchair Services were involved with the Wheelchair Collaborative, which was about 2004, I think. I was working in a wheelchair service at the time. It was great, and we learned a huge amount, and a lot of that is what I'm going to put into these next few slides about the process. So it's useful to begin with a process map. And this is basically a very long piece of wallpaper. Use the back of it or plain wallpaper, and you map the flow of the service from the referral of your client to them actually getting their chair. You'll need sticky notes, you'll need black marker pens, and you'll have arrows that go backwards and forwards because people will need to be seen more than once. And you can also put on that where referrals have gone on since the referral has come to you. So whether it's gone to social services already or whether you've had to do that. Then go back over that map and see where the bottlenecks are. And I'll talk a lot about bottlenecks. The bottlenecks are what hold things up. And these are where you need your sticky notes, because the bottlenecks are what's going to, is the areas that will be identified that you need to work on. So what causes a bottleneck? Well, very broadly, there are 4 areas. Is information or lack of it is usually the case. It's a really key issue, as we've talked about, getting the right information on the referral when it comes to you. Is it, have you got all the background, or does it literally just say person has MND? Does it say anything about the referrals on to other people? How do you get your referrers to give you as much as information as possible without actually making the referral page, the referral form 20 pages long so that you can capture everything. Perhaps a large note on it saying, if you've got any reports that you've just written from your visits, which for social services OTs or community physios OTs, this is an absolute goldmine of information. One of the other bottlenecks is we've always done it this way. And how often have you actually heard that? It's always been done this way. If it has always been done this way, then it really should be changed. Duplication of processes. Back in the wheelchair service, when I was first there, we didn't have a dedicated database. We had to use the one that was used by all the community teams, and it just wasn't sensitive enough for wheelchair services. So all the referral processes were written down in about 3 different places so that we could capture all the information. However, once we got our database, some of those continued, and then it was a case of, well, why are we doing this? And gradually those got dropped out, and it streamlined processes much better. So really that's duplication of, how things have been done as well. Communication, we'll communicate with the referrer. Pick up the phone, drop them an email, and just be persistent to get the information that you need. So on the following slides, I'm going to go through each of the different areas as Lynn did. So around that provision cycle, there's going to be lots of questions that I will be posing to you for you to consider. It's not exhaustive, but I hope they'll be helpful. And it's some of what I learned from working in wheelchair services for 18 years. So at referral, how is the referral made? Is it email, post, telephone? I mean, I don't know about you, but at the moment we're getting post about, in my house anyway, about every 3 days. So if somebody's putting letters and referrals in the post, they're going to get delayed. And how can they therefore be marked as priority and flagged up in the minute they drop on the desk or into the inbox in the wheelchair service? Perhaps on the emails, could you advise people, put in the subject line, new referral, MND, urgent? That's something that would then flag it up to the person receiving that email. That's right, okay, I'll open that one before the other referrals. If it comes by post, do they send them first class? Certainly where I worked, they were very reluctant to use first class post. You had to really consider it before you marked it as first class. With first class post having gone up substantially over the new year, I think there might be even less of that anyway. But perhaps at the top of the referral form, it could be marked and highlighted when somebody sends it in with urgent MND, so that it's flagged up. And if somebody rings you about a referral, which is likely to be a re-referral, that's great. You've got the referrer on the phone. Ask them all the questions you need. You may need to have a crib sheet so that with all the questions required, so that if it's an admin person who has picked it up, they then know what questions they need to ask and what information you're going to need before that referral can be triaged. So when it's triaged, what do you need? What are the bottlenecks? Information and more information. You can never have enough information about what the referral is about the client themselves. And it does make the triage so much easier. It does mean then that the therapist going out or the clinician going out to see the client is not turning up and looking very unprofessional because they haven't got much of the information. Who does the triaging in your service? Is it just one person? That can be quite common. I did all the triaging at one point. That means that when I come back after a 2 weeks annual leave, I've got 2 weeks of referrals and I've got clinics coming up and visits booked, and triaging ends up waiting because I just haven't got the time. What about having a couple of people, a couple of clinicians in the service who can do this? Take it in turns, one does 1 week, one does the next week, and set aside, and what I ended up doing was setting aside an hour every morning. So my first hour of the day was not going out and visiting people, because people in wheelchairs very often don't want to see you until after 10 o'clock. Use that time to do all the triaging. If they've been flagged up as urgent because they're MND, that will get them through a lot quicker. It means you keep on top of the referrals. Some services have a duty therapist every day. Perhaps it could be their role to do the triaging. So whilst they're not fielding calls that are coming in, they can actually also be trying to gather information, if they haven't got it, on the referrals that have come in. Specialist assessment bottlenecks, very common ones. Our clinic's booked up for weeks in advance, so that people feel that they've got an appointment in the diary, which is great. But is there any leeway? Have you got a few urgent ones kept back so that you can put in urgent clients? Whether it's for pressure care, somebody's changed completely, falling out their chair, or for somebody who's got MND. Is it a case of when you book up all your clinics, have a couple of slots in each clinic that can be booked at the last minute? Do you have dedicated MND therapist? Now, I know Lynn mentioned this, and that we did have the champions. That's not running at the moment, but is there extra training that needs to be done? Could somebody benefit from perhaps tapping into our services? Lynn, myself and Jenny have been very happy to come out and assist with services and assessment. And the more details about that later, or if you can contact us through MND Connect. When assessing, do you look to over-prescribe, which again is what Jenny mentioned, the neuro chair? And I explain it to patients that it does look a bit over the top, but actually it will keep them going with minor adjustments, possibly to switching and things like that. But it will be one chair, and that's hopefully all they will need as their needs change. Currently, we're using remote working. So I've done a couple of different environmental assessments for powered wheelchairs. One was over Zoom, the other was over a WhatsApp video. Does make the house look slightly bigger, so be aware of that. But it did work really well. It saves, it does protect you, it protects the client as well, because obviously they're vulnerable with their respiratory function. But it did work. I didn't actually end up meeting the client until I handed over the chair, but when I got to see the house, yes, it had worked, which was great. I must admit, I was really pleased about that. Ordering equipment. Lynn has mentioned ordering, but what about time for write-up? Do you have time to write up the notes immediately? After you've seen the person, have you got a dedicated slot when you get back to write it up, find out all the information that you need, spec up the chair, get the prescription sorted out, whether that's something you're doing yourself or whether that's coming from a rep that may have visited with you? Can you block out time either after that visit or the following morning if it's at the end of the day? What systems do you use for your ordering? Is it a central system, which means that you send everything to the company's main ordering system? Or is it quicker than that? Is it all done locally within your service? It goes to the procurement within your trust or wherever it is that you work. And that can then be flagged up as an urgent one. How do you follow it through? They do get lost in the system. We had a number of orders that got lost going to companies that they'd never received. We'd sent, but they hadn't received them. Some companies, I know, some suppliers will send back acknowledgement of order, and on that there will be very often an expected date of delivery, and that can be really useful. Do you have a follow-up system within your service to, you know, look up, right, well, I ordered XYZ last week, I'll check with the supplier, make sure they've got the order and see if they've got an estimated time of delivery, and see if things can be chased up. Otherwise, things can be sitting there, and then 4 weeks later, when nothing has been received, you find actually the supplier never got the order in the first place. Personal wheelchair budgets, as Jenny mentioned, there's not a lot of information out there. A lot of people are not knowing about them at the moment. If you were aware of the old voucher scheme within the wheelchair service, this is very much a similar thing, but they now call it personal wheelchair budgets. It is run slightly different. There are 3 different options, and they are slightly different from the old options that were within the voucher scheme. Do contact your local wheelchair service to find out how they are running that, but it is now set up nationwide. As far as personal wheelchair budgets are concerned, that's getting the information about those as quickly as possible, because coming back, if you're going to want to get a grant through the MNDA for a top up, say on a seat riser, things like that, that does take a bit of time, although the support services do try and be very, very quick about it. And if you don't hear within a few days, you can always follow it up. Very often it's us that puts in the grant request, but we need the personal wheelchair budget first to know how much grant we are requesting. Handover and issue and handover. Some of the bottlenecks here can actually be very similar to assessment. It's finding time in clinics. Is it the same member of staff who can see to hand over the chair? Because trying to pick up somebody else's referral can be really hard, and I know how difficult that is. So if you've seen and assessed, can you be that person that goes out and does the handover of the chair? When you've seen them for the assessment, is there that possibility that you might be able to book a slot for the handover? I know it's a little bit finger in the wind, but you never know. Some wheelchair manufacturers can get the chairs out very quickly. And I did get one chair turned around within 2 weeks out to the client with me there to do the handover. So it can be done if the order can be marked for somebody with MND. That time slot might not be able to be fitted or set up until after you've got the order acknowledgement. Again, the appropriate member of staff, if you can have the same person who did the assessment, that would be really good. Long appointment slots. Handover of a powered wheelchair for somebody who is thinking they don't really want this powered chair at the moment because they can still just about struggle around the house. Be very positive about it, but it might need to be a long appointment slot. There may be a lot of discussion with it. But the other thing is there may be a lot of specialist controls that are required. Do you have the right members of staff who are going to be able to set up the wiring for switching, for head controls, proximity switches, buddy buttons, and all that sort of thing? You know, are you confident in doing that, or do you need somebody else who is going to be there to do that? There may be drilling involved to fit foot straps or belts, harnesses, that sort of thing. Review. And Lynn mentioned review. How often is it done? 3 monthly is recommended, but people with MND can need review a lot quicker than that. But by overprescribing, what we're hoping is that that review will not need to be every week, that there will be some sense of overprescription, so that they just carry on into the extra needs that are on there. Things like tilt and recline. Powered tilt, it may be that they never use it in the first few weeks, but then gradually, as perhaps head control becomes more difficult, they use the tilt function more often. As they're using the chair more, they can't transfer into their riser recliner. So again, it's used more often. So tilt becomes very valuable. It may be the seat riser is the most important bit at the beginning, which a lot of wheelchair services won't provide, and we do appreciate that. And that's where the grant system comes in. So who does the review? Is it the therapist who, or the clinician, or the engineer who supplied the chair and assessed for the chair? It doesn't have to be them. It's helpful if it is, because you will understand any of the questions that the client might have. It could be admin on the telephone, an email just to say, hi, how are you doing? Is everything still okay with the chair? And it may be that you, again, need a list of questions to be asked to actually tease out if there are any issues. How are they done? As I say, they could be done by phone, they can be done by email, they don't have to be in person, and particularly in this climate, a WhatsApp video or a FaceTime call could be all that's needed. So if it's not the clinician who saw the patient in the first place, how can any information that is received by that reviewer get back, and how quickly can that be acted on? And if the client throws a curveball and says, there's, no, it's really, I cannot drive it anymore, I've lost all hand function, the joystick is I just can't use it now. What do you do with that information? Is that a re-referral? Do you have to go back to the original referrer and say, can you refer it again? Can you take that on as a referral, a self-referral, as a review of the wheelchair, and take all the information again back to the referral slide, getting all the information that you need of what the problems are, how quickly things have changed, and what you might need to do now? Can an appointment actually be made on the phone whilst you're talking to them, to say, okay, we'll get somebody out to you to see you, next week? The other, a big source of referrals, which Lynn mentioned, are the locality MDTs. I've started attending a few of these, and they have been very helpful. I hope any of the information that I give can be also quite useful from our point of view, because we do know quite a lot of these clients, either from the clinics where we're based, or we have been out to see them. We've helped out with services, as Lynn mentioned, with when they've been changeover of supplier of wheelchair service, and there's just sort of been a big black hole in the middle when databases were changed over and stuff like that, and nothing could be accessed and no one could be seen. So we're quite happy if we're there to offer information and possibly pick up any links to the wheelchair service if they're needed at that stage. Hope all that has made sense. Here are some of the references that we've alluded to. The NICE guidelines, that's the main NICE guidelines about MND. There's also one for respiratory. We haven't talked about respiratory function. That's a whole different ballgame. The ALS FRS-R includes the respiratory function. And then the other one, with the ALS pathways, the guide for how to use it. Hope that's been helpful. It's been a bit of a whistle-stop tour, but I think some questions have come in. I don't know if they've been answered all on the chat, but perhaps if anyone's got any more questions they would like to pose, they could either write them in the chat, or are we going to open up the microphones as well and invite people in?
I've just got the open up for.
Right, I'm going to stop screen sharing. There we go.
Thank you.
Okay.
Lovely. I will try and. Oh, it's just told me my internet is unstable.
Aye.
So I'm just going to bring things towards the end now, and we've been posting some links in the chat. I've posted some links to the FEW, which is the Functioning Every Day in the Wheelchair Outcome Measure. The WHOM is another one that I've used, which is the Wheelchair Outcome Measure. I didn't have the one for Alison mentioned, so maybe Alison, you could find a link for the one that began with the T, which are very technical, can't remember what you called
Toms.
it. That's it, the Toms. I was going to say the Tims, but
Really, it's Tim, not Tom, not Tim. I'll see if I can find it. Hang on.
There's another ALS research project called Tims, which is why I was going to say Tim. Anyway, so have a look in the chat for some links to some of the outcome measures. As an OT, I've used the COPM, which is the Canadian Performance Outcome Measure, which the OTs amongst you may be familiar with. It is an OT assessment outcome measure, and it is relevant to any field of or anything. So you can apply it to wheelchairs, but it's not a wheelchair specific one. But it just helps look at things a bit more holistically and from a client-centered point of view. So yeah, there was a couple of questions about funding and links and resources. So here's some up on the screen here, but I think Pauline has posted a lot of them on the chat as well. So please do feel free to have a look at those. MND Connect, the number at the bottom, and the email address are really useful resource of information to do with anything to do with MND. So I often ring them up, and things like holidays for people, wheelchair accessible holiday accommodation and things like that. So it may be that your clients ask you some random questions, and you could either find the information out for them or point them in the direction of MND Connect. The support grants, there are specific wheelchair support grants for people. So do look at the paperwork for that and send that in. The people that are reviewing these grants when they come into the office are not clinical. So the information you put on there needs to be written in layman's terms or quite specific. However, if it is complex, then you can, it will get passed to Alison and Lynn for them to have a look at from a clinical perspective. Or you can contact us directly and ask if there's any queries. The kinds of things that the MND Association are typically providing funding for include risers, as Alison said, attendant controls, sometimes some specialist head controls, but we've also helped people provide stuff that's a bit out there, a bit specific to their individual needs. So there's no real limit. The main thing is that we want to make sure that it is useful for the client and safe for the client to use. So thank you very much for listening to us today. Here are some links to do the evaluation, which would be really helpful if you could do. Apologies for technical troubles that we've had, but I've yet to do any webinar training or anything where they don't there isn't some kind of technical problem. So but thank you for listening. If there are any individual questions, perhaps you could put your hand up. If I stop sharing my screen, raise your hand or type something in. We've got some messages in there, that's fine. So to make silence. Okay, no one's piping up with anything at the moment. I'm just going to ramble on for a few minutes just to give anybody an opportunity to type anything if they're not raising their hands. So I don't know, Pauline, if you want to add anything about the grants or anything from that side of things.
Yeah, I mean, I think you've pretty much covered everything, Jenny. So absolutely, if you are supporting somebody with MND and their need isn't met by what's available through the wheelchair service, then absolutely consider a personal wheelchair budget, and think about the association when it comes to maybe funding those additional items, or in some cases we've made contributions towards wheelchairs, where perhaps somebody's needed something a bit narrower in terms of kind of footprint than might ordinarily be available through wheelchair services. So it might not be a grant that we offer towards a specific accessory, but it might be a contribution towards a wheelchair with the personal wheelchair budget route. And as Alison said, and Jenny, the team aren't clinicians, so it's really important that if you are going to apply for funding, that you include as much information and quotations as possible, and the applications are complete, because then it will sail through the process. I've also put a link to an email address, so if you'd like some more information on the support that Lynn, Jenny and Alison can provide you or your teams, then please do get in touch. It's probably easier to do it through the National Care mailbox, and then Jenny, Lynn and I and Alison can look at what sorts of requests for support are coming through. But absolutely, if there's things that you can think about that will benefit your team that we can provide, then do get in touch.
There's a question that's come in from the chat. Is it possible to be emailed the PowerPoint, as I've had to access via a mobile phone? I guess that's a question for Sam.
Yeah, the recording will be available after the event, and it will go up on the MND Association website, and we can also email the presentation to those that attended today, if that would be helpful.
Okay.
Brilliant, thank you, Sam. So I hope everybody's found it useful. It's the first, we've only just launched the pathway today, so this is the first kind of showing of it. We may run this again in the future. We'll absolutely take on board any feedback that you might have on how we can improve this, so please do fill in the feedback form. And if there are no more questions, then thank you everybody for your time this morning, and enjoy the rest of your days. Thank you.
Laura Collins, you had your thumb up a minute ago. Was that for a question?
If you want to unmute yourself, Laura. No, it wasn't. She's just typed. No, it wasn't. Thank you anyway. Okay.
All right.
Okay. Well, thank you, everybody. And you can all log off.
Thank you, everybody.